moms, children, as well as the maternal and child health providers. And I'll wrap up with a little information about how to access training and support, should there be any folks who are interested in learning a little bit more. There are definitely a few places in my presentation where the topics have been covered already, so I'll touch on a few points that I think are really important to share in this audience. One is to highlight a couple of recent recommendations from the U.S. Preventive Services Task Force. And I've shared a couple of these, both of these articles with you in your conference materials. So last year in 2019, the U.S. Preventive Services Task Force completed a pretty thorough review that they had conducted on assessing the benefits and harms of preventive interventions for perinatal depression in pregnant and postpartum women and in their children. They looked at a number of different intervention approaches, including counseling, pharmacology, education, supportive interventions. And they did find that there was convincing evidence that counseling interventions such as cognitive behavioral therapy and interpersonal therapy are really effective at preventing perinatal depression. They recommend that clinicians provide or refer pregnant and postpartum women and men who are at increased risk for perinatal depression to counseling interventions. And within that recommendation, they highlighted a couple of different interventions, one being the mothers and babies intervention, which is cognitive behavioral therapy approach, and the other, which is called the ROSE program, which is more of an interpersonal psychotherapy approach. They're cousins in the psychotherapy world. And I just want to comment with relation to this topic that it isn't I'm not trying to imply that there's no room for the other interventions. I know that we had some really helpful guidance this morning from Dr. Kirsch on effective pharmacotherapy interventions, and Bertie Meyer was talking about the catastrophes that can occur when folks go off of their medications. So this is really just to give some more evidence of counseling interventions that can be provided by any of the professionals in the network of providers that are interacting with women in these settings. We've talked a lot about risk factors for perinatal depression already today, so I won't go into these in great detail. But I did want to reinforce the idea that the term postpartum depression does not really capture the experience. And I'm going to reference an article that I think Bertie was referencing earlier as well, just to highlight that the timing and onset of depression symptoms can vary widely. And so when we think about the traditional framework of screening during pregnancy and screening postpartum, to keep in mind that there can be a wide range of in the timing of when depression can begin. It can begin in this study that I believe was with over 10,000 women. It broke down along lines that about 40% of women began to experience their depression symptoms after delivery, while a third of them began to experience those symptoms during pregnancy, and nearly a third had some depression before they became pregnant. So just being mindful of current risk factors as well as historical risk factors, including a family history, is really important when you're thinking about who we should be reaching out to provide intervention. So I'm going to get into a little more detail about the mothers and babies intervention. It is an evidence-based mental health intervention designed to address stress and depression. We frame this as a stress reduction intervention. We don't approach clients saying, you know, let's start this postpartum depression prevention intervention. It's really framed as a toolkit for reducing stress and managing our moods within the context of being pregnant, of being postpartum, of having an infant to care for. It can be delivered by home visitors and other paraprofessionals, and this can include health educators, community health workers, and just sort of thinking expansively outside of the typical clinical roles that are interacting with these women. It's both an individual and group intervention and can be delivered in person and virtually. There's a lot of virtual delivery happening right now with this intervention. I want to just share just a couple of points around, why we should be thinking about delivering a mental health intervention through a non-mental health system. And that is, really that there are so many barriers that can get in the way of people engaging with mental health services. Those can be financial, those can be cultural, those, and even just regional. In rural areas, there are often really an absence of adequate mental health resources. And the great thing about these relationships that clients can build with those paraprofessional providers is they might see them more often than they get to see the OB, or more often than other medical providers. And so there's kind of a long-term relationship that's built between the provider and the family, and they can be much more accepting of receiving a mental health intervention in the context of that visit. So I want to share a little bit about the evidence that Mothers and Babies has shown and where it can have an impact. Several randomized controlled trials have shown that the intervention can impact depression symptoms, anxiety symptoms, perceived stress, as well as increasing social support, coping skills, and preventing the onset of a full-blown, severe depressive episode. In some of our current research, we're seeing farther out more positive parenting practices and better early childhood developmental outcomes, including self-regulation and other social emotional outcomes. A couple of other sort of systems related outcomes that we like to examine show that women who were receiving Mothers and Babies prenatally were more likely to remain engaged with their home visiting program beyond the perinatal period, which is really key for those agencies that are trying to have a positive impact on that early childhood development and bonding development in the family. We've also seen better compliance with preventive health care. So getting those babies in for those recommended immunizations is something that we saw more compliance with among women who received the intervention. And I wanted to just touch briefly on how we're thinking about really building the capacity of the workforce who work with these families. And we've done some survey work in some statewide home visiting networks in Illinois and in Florida, where we've really tried to assess not only how is this intervention working for your clients, but how is this helping you in your capacity to address mental health concerns with the clients and patients that you're working with. And so we saw a great response in how folks were feeling about Mothers and Babies as a service for their clients, how well prepared they felt to deliver an evidence-based home mental health intervention alongside their other services. And just to back up a minute, the majority of providers that we've been training are not folks with psychology degrees or even social work necessarily. There's a broad range of educational backgrounds that may not have a lot of formal mental health training as part of the educational structure. And what I wanted to really spend a minute looking at here is looking at how being trained to deliver the intervention and participating in that, adopting this and making it part of practice was really linked to increasing confidence in identifying mental health issues with clients, increasing their ability and skills in addressing those and having open conversations rather than maybe backing away because you don't feel like this is your area of expertise. And really, you know, taking the time to prioritize working on mental health and emotional support and coping skills when there may be competing demands in the family. So this is really a key outcome that we're thrilled to see, not only in the impact of the intervention on women and children, but also in helping just build the capacity and confidence and competency of paraprofessionals in having a really great impact on mental health. Just touching briefly on who can benefit from the intervention. It's been designed as a preventive intervention, and so we kind of conceptualize that as women who might be in the mild to moderate range of depression symptoms, but also looking beyond that, looking at what kind of anxiety symptoms they might be having, what kind of stressors are they experiencing, and going back to you know, the list of risk factors that I've referenced and all of the other speakers this morning have referenced, keeping in mind that those who are at highest risk could absolutely benefit from the intervention. And now to get into just a little snapshot of what the Mothers and Babies course is all about. The foundational theoretical concepts include attachment theory, cognitive behavioral theory, psychoeducation, and mindfulness practice. So the basic foundation of the course is the idea that if we can recognize how what our mood is like, what our stress level is like on any given day, then we can make small changes in our behaviors or our thoughts or our interactions with others that can have an impact on rebalancing our mood. So to that end, each module in the intervention focuses on a core CBT concept. So the first module is pleasant activities. The second focuses on our thoughts and cognitions. And the last module focuses on our contact with others, our social support, and our communication with those in our support network. In the first session, we introduce how stress can have an impact on the mother-baby relationship, and we really start the conversation by normalizing the fact that everyone has stress, that there may be a lot of significant stressors in our lives that we may not have control over, but what we can do is take some control over how we respond and how we take care of ourselves and how we react. So we introduce the idea of tracking our mood, learning some mindfulness practices, and we build on the mindfulness practices throughout the sessions. We provide a variety of styles of mindfulness meditations with the idea that folks can find what works for them and add that to their toolkit. And we connect the practices to core MB concepts. So for example, engaging in some mindfulness practice or breath awareness as you are about to begin a pleasant activity with your baby so that you're able to be present and fully enjoy the experience rather than having the distractions of other thoughts. Our pleasant activities module focuses on the fact that what we do affects how we feel. So if we increase the frequency with which we're engaging in pleasant activities, that should have a positive impact on our mood. And we focus on overcoming obstacles to doing those activities that make us feel better, as well as identifying things that can be part of our everyday life, things that might just take a few minutes and be really brief and cost nothing, and just building in those healthy habits into our daily lives. We, of course, come at this with a lens of attachment and bonding with baby, and the idea that this is not only helpful for bonding, but also in the infant development. Our thought module focuses on how our thoughts can affect our mood and our stress level. And we begin by noticing what kinds of helpful and unhelpful thoughts we're having about becoming a mother, about the parenting we may have received growing up. And we introduce some strategies on how to reduce unhelpful thoughts, reframe those with more helpful thoughts, and also some conversations about how the way that we think can impact our future. And we also have this opportunity to teach our children healthy ways of thinking about themselves. And our last module, Contact with Others, focuses on how our mood is related with our interactions with other people. This involves thinking about all of the people in our support network and expanding sometimes who we consider to be part of our support network. We focus on communication style and helpful ways to get our needs met, as well as kind of navigating and negotiating some of those disputes that come up with these role transitions, so that we're able to, preserve the integrity of those supportive relationships while also being, being able to be assertive and hold our own ground. A little bit more about the logistics of the intervention. The one-on-one modality consists of 9 sessions. Those sessions are designed to take about 20 to 25 minutes each. And we've developed these to be integrated alongside another type of visit that is occurring. It can be home visiting, it can be visit with a health educator or maternal and child health provider. So the idea is that you can incorporate this mini session into another visit that you're having with a mom in your setting. Alternatively, if you do have the opportunity to engage over longer periods, especially if you know that you may not have access to visit with that mom for very long. I know, for example, there are maternal health nurses that focus on, connecting with moms after a high-risk delivery, but they may only see them for a couple of times in that first month. So there's certainly the option to pair up, double up sessions to get through them in a briefer time period. The group model is a 6-session model with sessions lasting approximately 90 minutes each. And we have seen some successful examples of groups being run virtually. And so it's really exciting to see how well this is translating in our current system of care, where much of it is happening in a remote or telehealth model. I want to just call out a couple of things in the works right now. We've developed a text messaging supplement to the intervention, which we've tested and seen that women who received the intervention, as well as text messages between sessions, had even better mental health outcomes than those who did not receive the text messages. And these are really to serve as reminders of the content that was reviewed, some encouragement to practice the personal projects, that skill practice between sessions. There are some guided mindfulness meditations that are linked to, and those roll out between each session. I will also mention, I didn't make a slide for it, but we've also developed a fathers and babies intervention, which we are refining and continuing to test. But this is something that we support in our training and implementation model of integrating other care providers in the intervention. And we're hoping within the year to have our freestanding fathers and babies intervention available for broader dissemination as well. Just to get back a little bit to how we are disseminating the intervention, while we do still have a number of research projects ongoing, we've learned enough to know that it works. So we've been doing a lot of public health outreach and providing trainings and consultation to support integrating a new evidence-based intervention into systems. So we do this by first meeting with agencies and organizations to find out, what kind of services do you provide? What does service delivery look like for you? And how might we adapt this to fit with your system? We provide training for not only the direct service providers, but we really want supervisors and consultants to be a part of that process so that after our initial time together, this is a more sustainable model in-house for additional training and supervision that doesn't require an external team. We typically spend about a year from start to finish between the training, providing regular monthly or biweekly consultation for implementation, as well as conducting some evaluation of how it's going and where the strong points are, where there might be some areas that need additional supports in order to sustain it going forward. And another piece that we really are starting to get into more is this train the trainer idea, so that we're really trying to expand access to the intervention across broader regions, so that it isn't solely relying on our availability, so that we're really able to share this out and have it remain a sustained intervention in practice. I have a couple of minutes left, but I would imagine that Lisa also wants to make some closing remarks, and I haven't even peeked at the Zoom to see if there are any comments or questions coming in. So I'm going to pause there. I've got our contact information up, and if folks have questions that they want to ask me, I'm happy to respond. And also, I just want to open it up back to Lisa, who might want to kind of bring home the day.
I don't know if this is as much a question, Erin, although anybody who does have questions, please feel free to put them into the chat box or the Q&A. But this idea that Dr. Pepra kind of ended with, which is to build, work on building coping skills with clients, that does stand out to me about the mother and baby course, is that it is based on building coping skills. Oh, we can't hear you. Your mute button.
It was if we had scripted that. It was a really great segue to show how, these developing more coping skills, and that being a really effective way to not only provide an intervention that can have an impact on mom, but these things can be shared throughout the family. So other supports in the family, teaching these coping skills to the kiddos as well. It's definitely an intervention that can have multiple generation impact.
And how widespread is it being implemented, the mother-baby course? I know you have multiple places throughout the United States, but I just was curious about how widely it's being used.
Sure. To date, we have trained about 300 individual health or human service agencies across 28 states. So we're in a lot of places. We're doing a lot more kind of statewide training and rollout these days, since it's easier to convene people in a virtual format. So that's definitely, there's been a lot of growth. We've recently been able to add to our team so we can meet the demand a little better.
Looks like we have somebody in attendance who uses the mother and baby course in Bloomington, Illinois.
Oh, fantastic.
Let's see. Do you accept referrals for every pregnancy or only one per mom? So programs that are implementing the mother and baby course, do they only attend, like, are they only enrolled for one pregnancy?
Sorry, that's my timer that I need to stop talking. So I've certainly seen in programs where women will participate in the mothers and babies group, for example, and then want to be a part of the next cohort as well. There's certainly been moms who've received the intervention with one pregnancy and then want to revisit that again. And the great thing about providing the training to kind of a variety of providers in a system is that, the patients and clients might move into different areas of your system where there might be additional providers who kind of speak the same language. They've had the training, they can relate to the concepts that moms have learned as part of the intervention. I did also want to mention that while the intervention has been designed and tested in the perinatal population, that we do also see this being used a lot with families that have slightly older children, especially in those systems where they're trying to remain engaged for 3 or 4 years during that early childhood developmental period. And it can be easily adapted just by reframing some of the examples so that they resonate with the family and their particular situation.
Okay. All right, Erin, we are approaching 1 o'clock. And there is a significant amount of information that Erin has already given me that I will pass along to our participants today. So there's more descriptions of the mother-baby course and how to kind of get more information from Erin about that resource. So I will be sending that along. So
Thank
Erin,
you so much.
So much for finishing us out today. It's, you know, there's been a lot of information presented today, and we appreciate you being here and talking with us about the mother-baby course. So thank you. Okay, so